Hello, everybody. Hope everybody's doing well. We're at that part of our class where it's kind of hard to communicate. We've got people outside of the classroom. You're doing your clinicals. I hope everyone's being safe. I hope that you're learning a lot. It's the only time in your career as an EMT that you'll do clinicals. So make the most of it. Ask a bunch of questions. However, there's some things I wanted to share with you. We looked at the final exam and discovered that trauma is our lowest out of all the scores. And so concerning a little bit. And so it felt like that we needed to dive into some trauma. We needed to look at maybe where the problem is for some of you. And some of you, the problem is head injuries. Okay, so that's kind of understanding the physiology of the head injury patient. So just kind of give me just a second here to fix my system up here. Not what I wanted. Okay, sorry about that. Trying to get it's been a while since I've done a video lecture, so anyway, hang on one second. There we go. All right. I'm gonna leave myself right there for now. Okay, so let's talk about it. We're going to talk about concussions. We're going to talk about contusions. We're going to talk a little bit about epidural hematomas, subdural hematomas. We're going to talk about increasing intracranial pressure. And we're going to talk about how to recognize that that's going on. So let's, a little bit to talk about, not a lot, but a little bit. Let's jump right into it. So concussions. All right, concussion. And what we can say about a concussion is that it is the stretching of the brain tissue, right? And during a concussion, you have stretching of the brain tissue. It usually is associated with a contusion, but it doesn't have to be. It does not have to be associated with a contusion. So that's kind of what separates the difference between a concussion and a contusion. Just think about the brain tissue itself. It gets stretched out of place, causing a concussion. So what is normally the chief complaint of a person with a concussion? And so normally the chief complaint would be a headache. Okay. That's normally goes, a patient can complain of a headache. Now, in a concussion, when we talk about the level of consciousness of a concussion patient, right? And so normally these will be patients that start off alert and oriented, usually times 4, right? And then they will begin to have a decrease in their level of consciousness. Ooh, this pen is trash. I mean trash. All right, let's try it again. So they'll generally have a decrease in the level of consciousness. All right. But in a concussion, at some period of time, the LOC will start to improve. It will start coming back up. So that is a concussion. And that could be the difference. If you are recognizing a patient with a concussion, there should be a decrease of LOC followed by an increase. Let's look at brain injuries for a second. Like that's not a brain injury, but let's continue to look at brain injuries. So let's look at the contusion. So what we have in a contusion, we have bruising of brain tissue. And this bruising of brain tissue can cause edema or swelling of the brain tissue. That's what you see right here in this figure right there. We see the contusion. And when we're looking at contusions, we need to think about what the physiology is behind them. So, contra-crew injuries. All right, contra-crew injuries. So, here's an example of the hammer striking the head. So, the brain is injured directly below the injury site, right here. To be injured directly below the injury site as the brain rebounds against the skull. So and no doubt there's gonna be injuries caused by this hammer, right? You're gonna have injuries to the skull from being hit in the head with the hammer. So there's that, but this brain tissue is going to go forward. And then what's going to happen? Well, if it goes forward at some point in time, it's going to come backwards to its resting place. And right there, it's bouncing off the skull. So there is an injury there as well. Here we have the brain is injured as the full force of the brain's weight. It's the opposite side of the skull. So I'm sure you all would agree with me that this is energy. Right? And this energy is traveling through and it's pushing that brain forward right here. Pushing the brain forward. What is the brain doing? It's bouncing, right? And so it's being moved and it could strike this side of the skull, being the opposite side. So even when we don't suspect a frontal brain injury, we can have one. And so that's the whole deal about contra-crew is you're going to have injuries from the direct force of the trauma at the injury site as the brain moves forward, striking the skull at full force, and then a return back to its resting place, and on the return back, striking the skull again. A brain contusion, causes that bleeding due to tearing of a blood vessel on the surface of the brain. But that would actually meet our definition if we look at the subdural hematoma. What do we have here? So the subdural is just that. It's below the dura, right? So they call it between the arachnoid, which is that little spiderweb part of the brain, and the dura. And you can see here, here is your dura. Right? So if I open up the top of the skull, if I pop open the top of the skull, I'm going to have to go through the dura before I see the blood clot. Okay? I'm not going to immediately see it. All right, so that is called the subdural hematoma. I've got something to add to that in a second. And I will add it. I'll come back to it because, anyway, I'll come back to what my thought was on that. So that's the subdural hematoma. All right, so here's the epidural hematoma. And so this is where we have bleeding between the skull and the protective covering of the brain, the dura. So here, if I was to open up the skull plate, right, I will immediately see the blood clot. I could remove the blood clot, just stop the bleeding, put the skull back together. So between the skull and the brain, and this is what I wanted to talk about, we can associate low velocity deacceleration injuries, all right, with epidural hematomas, along with associated with skull fractures in the temporal region. It only makes sense, really, because think about it. If I have a skull fracture here, there's going to be stuff that could possibly lacerate that brain right there. And so then the bleeding will be right here. So skull fractures, low velocity type injuries, can cause these epidural hematomas. That's important because when we're doing assessments, we're looking at the mechanism of injury. We have a low velocity injury and an associated skull fracture. We have to really be on guard for something like an epidural hematoma. All right, so let's talk about this acceleration, deacceleration type injury. It's very, very similar to what we already talked about. When we're looking at the skull here, it's hurled forward. So this is where not with the hammer, we have the direct energy coming from the hammer. Here we have the whole head moving forward. The head is hurled forward. That causes the brain to smash up against the base of the skull, right? And then the brain is slapped by accelerated skull on the way back. So what we've talked about so far is injuries to the brain tissue itself, right? And so think about this for a second. We have bleeding to the brain. The skull is an enclosed capsule and it's really tight in there. I've said it before, but it does not tolerate any other fluid that's not already there, right? And think about it, we do have fluid already here. We have CSF, central spinal fluid in here, right? That's in its appropriate place. And so not only do we have the injury from the blood, right? So not only do we have the bleeding, but as this pressure increases from this bleeding in the brain, because it's a very closed capsule, it's going to start putting pressure down here onto that central spinal fluid, and it will actually start pushing it out, right? Pushing that fluid out, causing a bigger issue, well, not a bigger, but causing an issue to become much worse, for sure. So what happens when we have this increased intracranial pressure? What happens? Well, let's talk about it then. Let's move this up a little bit. All right, so remember, this is the pons right here, right? And just below the pons, we have the medulla oblongata, right? And I think most of you know this, so I don't mean to bore you with this, but we have to talk about this for me to bring out the point here. So, it contains the medulla oblongata contains all of the major centers that regulate autonomic function. And so we know autonomic function to be blood pressure, heart rate, and respiratory rate, right? Blood pressure, heart rate, and respiratory rate. And remember what I said earlier. We have our bleed up here in the brain. We have our central spinal fluid. Oh, that's way too big. I really didn't want to go that big. Hang on. We have our central spinal fluid. And it's living in this cavity here. And the function of the spinal fluid, it adds protection to the brain, actually. That's a few other things too, but all right. So remember, increased intracranial pressure from this bleed is going to force this fluid out of its place as normally is. So now we've got blood, we've got CSF, and the brain gets very irritated. Well, this brain is going to start swelling. Remember edema, right? Edema, fluid. We have fluid coming around the brain here. So where's it going to go? Because this is an enclosed capsule. Well, remember the foramen magnum, this large hole here. But what ends up happening is the brain actually starts herniating, and it will start pushing out of the foramen magnum. It'll start coming out. We know that this is where the spinal column starts coming out. Not a good day. Not a good day. And so let's dive a little deeper. So remember about the blood pressure, heart rate, and respiratory rate. So here's the foramen magnum. We're getting pressure coming down here. And now we're going to start involving central nervous system. So you guys remember when we talked about shock. And so back up here just a little bit. Here we have these blood vessels in the brain. Remember blood vessels in the vein and the brain. And so what do you think happens? So this central spinal fluid is going to start pushing down, and it's going to start causing these vessels to constrict. All right, think about this for a second. Stay with me. Stay with me. All right, so we don't have as much blood pumping through this vessel, do we? But no, because the edema is pushing down on the arteries of the brain. All right. So what can the body do to respond to this? What can the body do? What does it do? Right. Well, let's explain it like this, just to add a little more to it. See this brain tissue, right? This brain tissue starts saying, hey, I'm not getting oxygen down here. Everybody can help me out a little bit? Can you guys help me out? I'm not getting oxygen and I'm going to start dying. No problem, the brain says. Just like in shock, it's going to release epi. I hate this pen so bad. But, oh crap. But my other pen, the other one wasn't working too well. Other pen, so I'm kind of stuck with this for a second. All right, listen up though. All right, starts releasing epi. Oh my gosh. Epi. Sorry, it's the best I can do for now. And norepi. Beta 1. Sorry, we get beta here, of course. Beta 1, beta 2, remember that? Blah, blah. Beta. Lots of beta. So what's that going to do? Well, Instructor Morris, you told us that anytime that happened, right? Anytime that happened, you have an increase in heart rate. We have if heart rate goes up, what happens to the blood pressure? Please, God, tell me. Tell me, what happens. If we increase heart rate, what are we going to do to blood pressure? We're going to go up. Remember what the formula for blood pressure is. Remember what the formula for blood pressure is. Look it up. Heart rate increases, blood pressure increases. Oh, okay. I'm just waiting. I'm waiting for somebody to say, wait a minute, heart rate can't be up because you said that in a head injury patient, what would it be? Right? What would it be? Blood pressure would be up. Heart rate would be down. Right? Right. I said it. And I'm not changing that. I'm not changing my story either. I'm not going to change my story. And I'll explain it in a second. I will. So we have an increase in the blood pressure. Why? Because we want to push more blood through this vein that's constricted. The brain says, hey, look, do what you got to do to save the brain. Because we're nothing without the brain. So it starts just literally pushing more pressure because it wants to increase the amount of blood that's up here. So it can't really increase the volume if it was losing volume, but it can definitely get it there more pressurized and quicker. All right. So what do you think now? I want you to think about this for a second. That's going on. You got this brain that's herniating through the foramen magnum. And now we have more central nervous system involvement. The spinal nerves are going to start being affected because of the pressure. What spinal nerves do we have here? It's C2, C5. What do we have? Well, how about the phrenic nerve? Phrenic. Heard. I didn't misspell it. You can't say nothing heard. You can't say, I can't even hear you right now. I hear you. Phrenic nerve. And what does the phrenic nerve do? Right? You got to know that because it'll get you on that. Right? Well, the phrenic nerve actually stimulates the diaphragm to contract. It does. So we said if you had an injury between C2 and C5, look out because 70% of breathing comes from the diaphragm. It'd be a bad day. All right, but we have another one down here. All right, so phrenic nerve between C3 and C5. Right? What about the old vagal nerve? Right? What about it? What do we know about that nerve, or what do we know? And remember, really, these are just the highway. The phrenic nerve stimulates the diaphragm to contract, obviously, but these are highways, right? And so we know the vagal is part of what part? Is it sympathetic or parasympathetic? Right? Parasympathetic. Parasympathetic. I'm not going to spell it out. My pen's not working great. Parasympathetic. So what does the parasympathetic nervous system do? Does it raise heart rate or lower heart rate? It's going to lower heart rate. I know you meant to say lower heart rate. It was on your paper. I know. All good. So the vagus. So we have the vagus nerve, the vagal nerve, right? And it's, where is it? It's like T2 through 3, 4, 5, 6, 7, 8, 9, 10, 11, T12. So through there, injuries to that area can stimulate or cut off the parasympathetic nervous system, possibly, right? But that's not why the pulse rate goes low. Nope, that's not it. That's not the reason. But you need to recognize these injury patterns, because, looking for my notes here. Let me hang on one second. So not only does we talk about the phrenic nerve, we also have the external intercostal muscles and the internal intercostal muscles that get stimulated as well. And so here we have the phrenic nerve doing some of that as well. So look out for problems with the phrenic nerve and look out for vagal nerve. So if you have this, but I'm saying it's possible because what? Because herniation, right? You got this herniation going on. It's going to affect these spinal nerves. It's going to affect the spinal nerves. So think about that for a second. If your respiratory rate lives up here in the medulla oblongata, and so does your heart rate, so does your blood pressure. If we have a lot of swelling, we can see some rhythm disturbances in the respiratory rate from increase in cranial pressure, and that is why. So both these centers, not only because of the control of respiratory rate by the brainstem, but also the involvement of the phrenic nerve and the pressure it puts there as well. That's not why. So let me slide down here and fill you in. Do you guys remember baroreceptors? And so baroreceptors, what do they do? Baroreceptor. I believe I spelled it right. But you know what I mean if I didn't spell it right. Baroreceptors. Yep. What do they do? What do they monitor? Right? Well, we know that what they're doing is they're monitoring blood pressure. They're monitoring blood pressure and the fullness of those arteries. So if they feel like there's not enough blood there, then the baroreceptors are going to say, hey, let epi and norepi out, because I'm losing blood. Well, here's your low heart rate. This is where it comes from. Baroreceptors don't feel like they're losing blood. They don't. They're like, we have volume. We're okay with volume. What is going on? Baroreceptors say, too much blood pressure, turn it down. Turn it down. So remember, we talked about blood pressure. How you increase blood pressure? Well, you increase preload, you increase heart rate, right? Those are the ways to get blood pressure up. Well, the baroreceptors also could say, hey, we got too much. So how do you get blood pressure to come down? Same way. Same way. Reduce the heart rate. Reduce the heart rate. By reducing the heart rate, you're going to hopefully bring the blood pressure down. But the brain is overriding baroreceptors. Are like, dude, you're just a receptor and I'm the brain. We're going to do what we want to. The brain says, I'm going to override you. Parasympathetic nervous system's always the stepbrother that never really gets the attention it deserves. And it's like, no, I agree with baroreceptors. We want to be out and about. You're getting this fight between this because there's brain damage. But that's why you have a low heart rate. So what is that called? Cushing's triad. Cushing's triad. And where we have a elevated blood pressure, we have a low pulse rate. Running out of room here. Low pulse rate and an irregular respiratory pattern. This could be failure. Probably will be failure. Where you have a patient who breathes really fast, and I don't know if any of you guys have had a chance to see it. But you will have somebody breathing 14 times deep, and then an period of apnea where they just stop breathing. And they may stop breathing for 25 seconds. And then they'll breathe deep and fast in a rhythm, 15, 20 seconds, and then it's done for another 10 or 15 seconds. Then they may breathe 2 times and stop. Very irregular pattern. Why? Well, we said why. We said why. Because here is your respiratory center of the brain. It's pressure, increasing cranial pressure, pushing downward. It's bothering it. That's one problem. And then spinal nerves down here may be pressured as well, and they're not contracting the way they should. Okay. That is what I wanted to talk to you today about. I don't know how long I've went. This system has updated. There it is. I see. It's been exactly 33 minutes. I wanted to keep it at 30. And so there you have it. There you have it. Be careful out there. Study hard. And call us if you need us. Get on JB Learning and start doing some tests. I hope you understand this now. Right? I hope you do. Because if you're asked a question on registry about what's wrong, is it increase intracranial pressure? Is it this? Now look for the blood pressure being high, pulse rate being low, and an irregular respiratory pattern. Okay? Have a great day and look forward to seeing y'all back in class.